Is it 7? Anand, shall we start?
Yes, sir. We can start, sir.
Okay. Good evening, everyone. My name is VK Kapoor. I am a professor of surgical gastroenterology at the Mahatma Gandhi Medical College Hospital in Jaipur. I have been here for last about 3 years. Before that, I had served the SGPGI in Lucknow for more than 3 decades. I am sorry that I may not be able to attend the entire session because I am currently in Chile and attending an international core group meeting for gallbladder cancer, which is my area of interest. So I may log out sometime in between, but my other colleagues will continue the session. Mahatma Gandhi Medical College Hospital is a private medical university hospital, a tertiary level hospital with 1,500 beds. We have almost all super specialty courses, DM and MCH, which are there in the list of the National Medical Commission. And we have a very robust kidney and liver transplant program. Now we are doing almost 5 to 6 liver transplants every month. And my colleague, Dr. Anand Nagar, is a member of the HPB surgery and liver transplant team. And he has also been handling this online educational initiative, which we started 2.5 years ago at MGMCH, Jaipur Surgical Tutorial. He has been coordinating all the activities. Every Saturday, 9 to 10, we conduct online classes for MCH and DNB students in GI and HPB surgery. And recently, we started a Jaipur Surgical School, which is on Friday evening, 3 to 4, because the students in Africa, they said that 9 to 10 Indian time is very inconvenient time for them to join. It's very early morning for them. So recently, we've started that every Friday. And then we thought that there are certain topics which are of interest to surgical students, and they need a kind of a capsule-like teaching on these topics. So we started these master classes, which are held last Thursday and Friday of every month from 7 to 9 p.m., 2 hours on 2 days, so 4-hour session. We've already done 4 master classes on living donor liver transplant, safe cholecystectomy, chronic pancreatitis, and what was the 4th one, Anand?
Acute pancreatitis.
Acute pancreatitis. So this month it so happened that both I and many of my colleagues are not in Jaipur because of conference commitments. And also I have been thinking about it. I've been talking to Anand about it, that how to manage a critically ill patient has to be the surgical residents also should know the basic principles. And that is why I requested the team of Anand and Ravi, who are the backbones of our transplant program, to organize and arrange this masterclass. And I'm very grateful to all the faculty who have accepted the invitation. RK, of course, is my former colleague from SGPGI, so he cannot say no to me. Thank you, RK. And I must also put on record the technical help provided by one of my other former fellows from SGPGI, Dr. Avinash Tank, who is now GI and laparoscopic surgeon in Ahmedabad. His technical team provides online support for all these online activities which we do. And all these sessions are recorded and they are uploaded on the Jaipur Surgical Tutorial YouTube channel. So with that background, I will hand over to Anand to introduce the coordinators, and then the coordinators can take on. Thank you very much.
Thank you, sir. First of all, thank you. And then I congratulate Dr. Ravi and Dr. Anand, who make us such a very good program for our surgical students, not for surgical, for every anesthesia and the critical care students. And this before making the program, we have discussed regarding what topics should we choose, and then we make a very simple topics, and they acknowledge all the topics to everyone and the great faculties we have for these topics. So our consultant with me, Dr. Ravi Jain, he is assistant professor critical care at Mahatma Gandhi Hospital, and Dr. Anand Kumar Jain, he is a assistant professor in Department of Organ Transplant Anesthesia, and he's with us for the our transplant patients, not for the transplant, for the pre-operative workup of the patient in the HPB ICU. So I hand over to Dr. Ravi Jain and Dr. Anand Jain for the further starting of this our Jaipur surgical tutorial. Dr. Ravi.
Yeah, thank you, Kapoor sir. Thank you, Dr. Anand, for this formal introduction. Without wasting much of time, I would like to introduce our first effort. First of all, we made this with common consensus between me and Anand and Kapoor sir. Obviously, Anand Nagar was also involved in making the topics. We requested many faculties across the nation and could pull out some very active members of critical care fraternity from across India. So we are presenting surgical critical care masterclass, the fifth masterclass of Jaipur surgical tutorial to you. Yeah, thanks again to our patrons, and I'll hand it over to Dr. Pankaj Anand. Dr. Pankaj Anand is a chairperson for this particular session. For first two talks going to happen over here. Dr. Pankaj Anand sir is head of the Department of Critical Care Medicine as well as Internal Medicine at Fortis Hospital in the city of Jaipur. Dr. Pankaj Anand is a very active critical care physician in our societies, in our fraternity. He is a former secretary of ISCCM Jaipur branch also. Dr. Pankaj Anand is a avid learner as well as a very prolific speaker and teacher. I'll hand it over to you, Dr. Pankaj Anand, sir. Dr. Sir also has a very unique initiative of ACE Academy. I wish to learn him from, hand it over to him, and he will introduce our speakers from here on. Sir, please.
Good evening and welcome. Let me first thank the entire organizing team, Dr. VK Kapoor sir, for having the vision and the wherewithal. You know, I'm practicing critical care for the last 23 years, and most of the surgery people leave the patient to the care of the critical care guys once at the door of the ICU. So it's very interesting and encouraging to realize that the surgeons are now actually learning the intricacies of critical care, which is no more a domain of the physician. We all are equally should be informed and involved in the process of decision making. Now, about today, we have some very interesting topics lined up for this. And the first speaker is my old friend, Dr. Yash Javeri. Uh, I've been following him for the longest time that I am in the critical care. He's one of the most uh, active, prolific person, not just in the field of critical care, but also he has a unique quality of bringing everyone on a common platform. He's a big player on the scene of the Indian Society of Critical Care Medicine, and not just in India. He is a well-known personality across the globe. His core areas of interest, as you can see, are sepsis, uh, antimicrobial stewardship, ethics, trauma. He has a huge list of educational achievement. I don't think to us critical care guys he needs any sort of an introduction. And as far as the surgeons are concerned, you'll get an introduction once he starts speaking. And he's going to speak on a very interesting topic. Uh, what happens when do you involve the critical care team once when does a surgeon involve a critical care team what should be the rapid response even before the critical care guys come in. So you have a patient, either you operated or he's come to the ER and you are there, and what are the important points that you should know, and how do you decide whether this guy needs ICU care or not? This is, sounds very trivial, but this is a very important decision. And of course, this can make a difference in the life and death. So I now invite Dr. Yash Javeri to please speak on rapid response and critical care outreach. Who goes to the ICU? Dr. Yash.
Thank you, Dr. Pankaran. Thanks for the kind word and introduction. And at the onset, I'd like to thank Dr. Kapoor for a very noble initiative, much needed. And we all understand that critical care, although it is practiced within the walls of critical care ICU, but it happens everywhere across the hospital. And in smallest intervention by a nurse, by a surgeon, by a medical officer can change the outcome. So we will play the presentation. Thank you.
Good evening, friends.
At the onset, I'd like to thank Dr. Kapoor sir and my dear friend Dr. Ravi Jain for the kind invitation to Jaipur Surgical Tutorials, a very innovative initiative, and I'll try to do the justice to the topic. My topic is rapid response team or medical emergency team, whatever you want to call. This is a part of critical care outreach. Who goes to ICU? So the talk is around the sick patients in ICU who are called by rapid response team and what is our input at that time and who goes to ICU. Rapid response team or medical emergency team can be changed interchangeably, used interchangeably. So goals of this talk are to understand the early identification and assessment of signs and symptoms of critical illness. A stitch in time saves 9. Time is essence, time is life. We all know that. We'll discuss the significance of early medical intervention. We'll discuss how to cut down the long process of calling and how to fast track the process of the right healthcare provider reaching the bedside in a very, very short time span. We'll emphasize the principle that resuscitation and assessment should occur horizontally. We'll try to emphasize on ICU admission criteria and will dwell upon rapid response team the role. We all know what we have sick a lot of patients nowadays, surgical patients by virtue of their disease, major surgeries and other interventions are little serious patients, and often they can go in a life-threatening condition. This demands early recognition and intervention. A small intervention can save the patient, and it can save a major intervention which could be required later on. Treatment and search for diagnosis should occur simultaneously. Can we predict which patients will require ICU and which patients are seriously ill? Yes, there are some tools like emergency admissions, comorbidities, advanced age extreme, I would rather say, prolonged hospital stay, malnutrition, immunosuppression, severity of illness, post-anesthesia, bleeding, rebleeding, massive bleeding, prolonged bleeding, even small amounts, drug or alcohol dependencies, some scores like Apache 2 or injury severity, and many other scores, clinical course of the patient. This is most important, and the lab parameters. So yes, there are some tools to predict, but at times patient can deteriorate without any red warning signs. So what are the calling criteria for medical emergency team? Any serious deterioration, it could be airway, breathing, circulation, bleeding, neurological deterioration, or a simple thing like something is wrong with the patient and I cannot pinpoint what is wrong. And this happens with all of us. Even after a day or two, we are not able to pinpoint at the problem, but we know that something is wrong. So such patients and patients who have these physiological perturbations, they require urgent attention from a rapid response team. We can again classify them A, B, C, D, E, airway issues, airway compromise, breathing becomes striatus, breathing respiratory arrest, tachypnea, bradypnea, respiratory acidosis, circulation like cardiac arrest, hypotension, uncontrolled hypertension. We generally follow again this ABCD approach, and this approach we have to follow always. Airway, breathing, circulation, disability, E is exposure, E is evidence, and E is focused examination. Immediate investigations and appropriate monitoring should be initiated as soon as we recognize a life-threatening physiological disturbance. We might not be able to diagnose pinpointly that what is the problem. But if we say a patient is hypoxic, we have to give physiological support till we arrive at a fixed diagnosis. Many of these critically ill patients will get help with oxygen and fluids, but again, we have to tailor it according to the need of the patient. We can also use this direct methodology. D is for detection using the history, physical examination, cardiovascular respiratory examination, ultrasound at bedside. Then we do intervention depending on the cause of the problem. Intervention, once we do the intervention, whatever the problem is, we have to reassess the patient. Effective communication is always
required, especially in times of crisis. The greatest source of injury and death in healthcare is poor communication. The more complicated the patient, the more important it is for everyone to communicate their perspective to the team. And you have to respect everybody's input, more so in crisis. Delegate the sensitive task and ask for completion. And yes, teamwork makes dream work. Also in crisis, it might be rapid response team, code blue team, Crimson code, whatever code we talk about. Teamwork is must. Surgical patients who require critical care, they are more challenging, they are more precious. The anatomy is altered, the physiology is altered. Surgical insult has already happened. It's a sort of trauma. We all know that. There could be surgical and non-surgical causes of illness and deterioration. We have to always remember this. Always remember that do not work upon pre-packaged diagnosis. Always give a fresh look to the patient when you arrive at the bedside. Initial workup should be towards physiological diagnosis rather than a fixed diagnosis, which is the final diagnosis. Look at the charts, look at the physiological trends, recent and past surgical history, lab and ancillary testing as and when required. Most of the time, an arterial blood gas tells us what is required. Surgical patients might require ICU for the illness, for the severity of illness, for monitoring, for bleeding, for respiratory issues, for thermal disorders, metabolic acidosis, respiratory acidosis, for coagulopathy, or for monitoring at times. I'll give you a case scenario. This guy you find on the roadside. What are your priorities? Think in your mind. If you have thought anything except ABC, you have thought wrong. So ABC will always come first. However ghastly or fascinating the injury or problem looks like, always focus at ABC. If you do this, all your patients are going to improve. Speed is life. If you are slow, you lose the patient. Another dictum, there is no surgical or medical disease, especially in court situations. So work towards physiological diagnosis and stability. Do not be bravado that I can do this. This cannot happen to me. Always work as a team. Denial. Never be in a denial. This cannot happen. Medicine does not work like this. Anything can happen. Sorry to say, but surgical colleagues, especially, they will always say bleeding cannot happen. There is no surgical issues. We have to come out of that mindset. Work towards your thoughts. Involve the specialists, get a scan, get other specialists involved. And if you find the problem early, the solution will be early and easy. Acknowledge the issues, respect the inputs from other colleagues, even from the nurses. Critical care is not a location. It is a level of care and expertise that seriously ill patients require. This was said by Sir Peter Safar, his father of resuscitation. Why is there need for rapid response team? We are already in hospital. Patients are being monitored, but the risk of death in hospitalized patients is huge. We have sick a lot of patients in the wards. And our code blue reviews everywhere on the globe showed we had 24 hours or more to look at the deterioration, to give our inputs, but we failed. That is why this rapid response team or code blue team arrived. There's constant need to improve and excel, accreditation required, and we want timely, swift care to arrive at the bedside when the patient requires it most. The cycle should not be a prolonged cycle with lot of red tapeism in it. Resident, nurse calling, resident calling, consultant calling, the HOD calling, the consultant back, then consultant calling, the ICU director calling, the duty. It should be fast, and we have to cut across all these redundant pathways. So where were we failing? We were failing in planning. Our assessments were poor. Assessments were often ignored or poorly done. Failure to communicate, patient to staff, staff to staff, staff to physician. Failure to recognize deteriorating patient condition, because the healthcare provider could be stressed, there could be burnout, it could be late in night or early in morning where the reflexes are poor. So we are sitting on a burning platform and patient's life were at stake. So we have to cut down upon this redundant pathway, what we talked about. This traditional system is prolonged. We have to make it a fast-track system. Patient deteriorating in ward, nurse, medical officer, frontline healthcare worker does a rapid response team. The rapid response team member arrives. They give their input, and if required, the patient is shifted to H2 or IC, whatever is required. So the calls for sick patient will no longer be delayed. The complicated call process is out. Ward patient will get a swift care with a whole lot of team. And this is how the RRT works. This is from the first consensus conference on medical emergency team. In patients with sudden critical abnormalities in vital signs, a failure to react promptly or commensurately escalate care constitutes a failure to rescue and may result in a serious adverse event. So, it is not only failure to recognize, but failure to escalate care also, which constitutes failure to rescue. If your hospital, your team is not able to escalate care, you have failed in your duty towards patient. So what is the composition of RRT? RRT composition depends on your local HR. It depends on your local context. Intensivist or intensivist, senior intensivist or senior medical officer who is looking at the ICU, emergency physician, critical care nurse, team leader of that particular area. These are the key members generally, but intensivist or anesthetist or physician can be used interchangeably. It purely depends on what resources you have. But even small centers like 40, 50 bed, we are able to do a good RRT team and we are able to save lives. So whatever size of hospital, primary, secondary, tertiary, RRT team is must. What are the key features? They should be able to respond immediately when called. They should be on-site and accessible, and they should have basic critical care skills like intubation, resuscitation, a big IV access when required. So these are basic skills which even a critical care nurse or a medical officer or an emergency medical officer possess. So your team should be in place, whatever level of healthcare setting you are working in. Aim, as we discussed, is early intervention and stabilization, prevent of arrest situations, and decrease in code blues which are occurring outside ICU. This is our old hospital, looks very, very complex, but to simplify, patient deteriorates, the nurse or the medical officer notices it, whoever is the frontline healthcare workers, they call the code blue. You have a dedicated number which goes to the exchange, and there is an announcement code RRT on second floor medical floor, room number 204. And the rapid response team rushes to the center. You can see the team constitution is different at different centers, what I was trying to stress upon. So RRT teams arrive within, say, 3 minutes. It could be even smaller in smaller health setups. They assess the patient. They stabilize their patient. If required, they shift the patient to ICU after stabilization. They assist with transfer and communicate with the primary team, and they educate and support and counsel the family as well. So we follow this SBAR communication tool. Suppose I am doing a RRT. I am in room number 204. Now suppose I am calling the RRT. Hello. I am Dr. Yash Javeri speaking from room number 204. Patient Mrs. Vinoda Sharma is having tachypnea. Her respiratory rate is 35. Patient was admitted for cholecystectomy, and my assessment is that you should be calling an RRT and it should be urgently attended. Thank you. The exchange person, it could be even smaller. The exchange person calls RRT room number 204. That is it. And the whole team arrives. Background, you have to look at reason for patient assessment, ABCDE assessment. What the problem is, why are you worried, and what is your recommendation? What do we need to do? So this SBAR model of communication, although I am discussing it in RRT, but this has to be communicated for all healthcare communication. tell the situation, tell the background, your assessment of the problem, and what do you recommend. But for RRT or Code Blue, it is not such a prolonged communication. It is very, very small. Room number 204, RRT. But otherwise, you should be following this whole section. Another important thing, once you go and see a patient, you have to tell the senior at time. Utilize this tool, CUS, concerned. Patient's little tachypneic 25, I am concerned about my patient. Patient's saturation is now 90% on 5 liters. I am uncomfortable with the situation. Patient is breathing very, very fast, tachypneic, his saturation has dropped to 80. The safety of my patient is at risk. So whenever you communicate, always follow this tool in your SBAR model. SBAR briefing with utilization of this CUS statement. This will make your communication more strong. And the role of subjectivity will go away. You will convey a very, very crisp message to the concerned person. I am concerned, I am uncomfortable, safety is at risk with the SBR model. Documentation, whatever you do, this is a RRT form. The reason for call could be varied. Just a simple reason could be the patient does not look good. I am unable to pinpoint the reason. Or bradycardia, tachycardia less than 50, 130, systolic blood pressure less than 90 or more than 180. Acute blood pressure changes, low or high, bradypnea, tachypnea, significant bleed, altered mental status, sudden loss of consciousness, new focal neurological deficit, worsening hypoxia, oliguria, chest pain, critical lab values. So these are the triggers. Then you write the situation, you write the background, your assessment, and your recommendation. Physician read airway, patient needs intubation, patient needs defibrillation, and you notify the treating consultant. So this is about the SBR model, CUS, and the rapid response team call. Now, the team has assessed the patient. Not all patients will be requiring ICU admission, but many of them will require. Out of, say, 100 RRTs, almost 40 to 50% of them require ICU or high dependency unit. Which patients will require ICU? Critically ill patients who have organ dysfunction, like hypoxia, oliguria, who require intensive monitoring. Life support, like ventilation, BiPAP could be at the ward or in the SDU or ICU. Invasive hemodynamic monitoring, arterial or a CVP, ECMO, pacing, defibrillation. These patients are obviously requiring ICU and they are priority 1 patients. Where priority 2 patients, these plus patients who have lower probability of recovery and less likely to receive intensive care therapies. These are generally palliative care or end-of-life care support patients. These patients, you have to make a judgment in consultation with the primary admitting physician. If the physician feels the patient should be in ICU because he has been talking to the family, you admit to the ICU, otherwise the patient is monitored in the ward. So these are the basic indications for ICU admission. It could be intermediate medical unit also. The indications for ICU admissions would are airway, breathing, circulation issues, hypothermia, hypothermia, bleeding, coagulopathy, any organ support which is required, any invasive monitoring which is required. Now you have launched the RRT. It takes time to be effective. How do you look at the effectiveness of RRT? Did you decrease on the code per 1,000 discharge? Codes outside the ICU decrease. Number of unplanned ICU admission from ward, did they decrease? What was the utilization of the RRT? What is the mortality in your RRT patients? This is a 2x2 matrix. This is from IHI, Institute of Healthcare Improvement USA. Box 1, patients admitted in ICU for active treatment. These are the right patient which have to be admitted in ICU. Box 2, admitted to non-ICU patient for comfort care only, like a patient with CA, pancreas, and metastatic disease, admitted in ward for comfort care. Again, this is right. Box 3, I will show you the boxes in the next slide. Admitted to ICU for active treatment. This is also right. Whereas box 4, admit to a non-intensive, admit to ICU for comfort care. Patient who is not requiring ICU is admitted to ICU for comfort care. This is a wrong patient. Okay. And patients who are requiring active treatment, patient in shock, admitted to ward, again it is wrong treatment. So your site of care should be very, very clear when you are shifting the patient from emergency or from operating theater. If your site of care is wrong, it will be problem. Comfort care only, you should not be admitting in ICU. Okay. Yes, comfort care only, ICU admission again wrong. It should be in the ward or in a palliative care ward. Whereas if the patient requires active treatment, patient should be admitted in the ICU and not in the ward. Active treatment, ICU, non-active treatment, ward. Palliative treatment, ward, not in the ICU. So these patients, which patients? Patients requiring active treatment, but they are admitted outside of the ICU. It could be from the emergency, it could be from the operating theater, it could be from the ICU. You shift the patient to the ward and say after 24, 36 hours, you recognize that there is a problem. Patient might require a readmission to the ICU. This is the area, this is the opportunity for application of the rapid response trigger 2. And this is where you can bring down the mortality drastically. This is again the campaign from IHI. This is about 15 years old, 5 million lives from harm. You have to protect these many because these many patients were dying in US from iatrogenic injury or from failure to resuscitation. The tagline which they use, some is not a number, soon is not a time. Every life counts. So any RRT, it could be a futile RRT, it could be wrong trigger and patient could be well, but do not discourage such RRT, especially in the beginning. Respect those RRTs. One wrong RRT does not cost you anything. But if you miss on an RRT for a critically ill patient, it could cost life to the patient. So some is not a number, soon is not a time. Every life matters. If you are concerned, so are we, call RRT. Now, people are going even farther. Family triggers. Family looks at the patient, not for India probably right now, and finds something grossly wrong. There are systems where there are triggers from home. Pediatric triggers are different, obstetric triggers are different, medical emergency warning signs, modified early warning signs are different. Whatever, you have to establish simple process for activating the rapid response team. You have to brief your team, plan, practice RRTs. Once you're not able to arrive at a problem, do a brief huddle, discuss amongst yourself or call for help as we discussed. And after every RRT, do a debriefing, what went wrong, what went right. This is an opportunity to educate the ward nurses, the ward MO, the primary consultants. Look at the root cause analysis. This is an opportunity to improve your quality of care. Do audits and peer reviews of RRTs and code use. As we discussed, this is the future of RRTs, early warning scores from the monitor, computer-generated early warning scores, computer-generated codes, fully automatic versus semi-automatic, the time will call. Whatever model you apply, the simpler, the better. Slowly, there will be hitches because there could be fake calls. But slowly and eventually you'll start to love it, especially the RRT team members, the intensivists and the nurses, because you have an opportunity to save lives and for which probably we became doctor. This is what we published. This is a very old article we published from 2014 International Journal of Critical Illness. Evaluation of rapid response team, implementation in medical emergency, a gallant evidence-based medicine initiative in developing countries for serious adverse events. The background was RRT being implemented in developed country with aim of early recognition. We took data for about 6 months and the outcomes were studied. I will straight away jump to the conclusions. Implementation of RRT in this hospital was as well with reduced code blue events and its attendant mortality outside the ICU settings also decreased. but it was a small study because our numbers were small, only 41 RRTs. Tips when getting started: no call is a bad call. Do not be punitive and criticizing to the nurse or the medical officer who gives a wrong call. It happens. Initially and continuously communicate, communicate, communicate. You cannot do enough of this. Be systematic and relentless with your communication. Share the success story, review the failures of RRT, and do a huddle and debriefing after every RRT. Take this an opportunity for education of your nurses, of your medical officers, and other healthcare providers. If you are concerned, so are we. Call RRT when required. So what have we learned? Some is not a number, soon is not a time. If you are concerned, so are we. What is concerning now can be life-threatening later. Eliminates barriers to calling for urgent assistance and call RRT. Thank you. I will invite questions and comments.